Okay, good evening everyone, and a very warm welcome to our webinar tonight from Benenden Hospital, this evening covering the topic of hip and knee replacement surgery. I'm Phil, I'm your host for this evening, and I'm joined by our expert presenter, Mr. Alex Chipperfield, who is our Consultant Orthopaedic Surgeon here at Benenden Hospital. And just to give you an overview of the format of the session, Mr. Chipperfield's presentation will last 30 to 40 minutes approximately, and that'll be followed by a Q&A session. And you could submit your questions for the Q&A session throughout Mr. Chipperfield's presentation or at the end of the presentation, and you can do so using the Q&A icon at the bottom of your screen. And you can submit your questions anonymously, or you can give your name. And we should remind you at this point that if you do give your name, that this session is being recorded. If you would like to book your consultation, we will be providing contact details at the end of this session. That's enough from me for the time being, and now I will hand over to Mr. Chipperfield.
Thanks very much. Good evening, everyone. Thanks for dialing in tonight. My name's Alex Chipperfield. I am a consultant orthopaedic surgeon here at Benenden, and I'm going to talk to you today about hip and knee replacement. So essentially, I'll talk a bit about myself first of all, and then about where we are today at Benenden Hospital, and then I'll give you an overview of hip replacement surgery and knee replacement surgery, looking at both conditions, both treatments, going through the causes, consultation, treatment options, and likely outcome of surgery. And then there'll be the Q&A session at the end. So me, I'm Alex Chipperfield. I qualified in London as a doctor in 1997. I trained in the southeast of England, and then before I became consultant, I did a fellowship in hip and knee replacement surgery in Sydney, Australia. I've been a consultant here in Kent since 2010, and surgeon here at Benenden for the last 11 years. I'm the hip and knee lead at Benenden now, and also a member of the Hip Society. I specialise in primary and revision hip and knee replacement surgery. Keep going the wrong way, sorry. If you don't believe me, you can look me up on the internet. These are a few websites and pages where you can look at me and read about what people have said about me and where we work as well. I'm what we tend to call a high volume surgeon, so I do a lot of hip and knee replacements. It's how I spend most of my time. I did 6 of them today, so we do a lot here at Benenden, and it works out that I do probably about 3 times the national average of hip and knee replacements compared to other surgeons around the country. So I do them regularly, and we know what we're doing. At Benenden Hospital here, we're the leading provider of hip and knee treatments in Kent and Sussex, according to the PHIN last year. And I think, I don't know if any of you have been to Benenden, but you'll find that it's a clean and calm environment. It's a nice place to be. It's a nice place to come and visit. There's an experienced team of consultants and therapists and nurses, and we get high patient satisfaction rates, partly due to the quality of our surgery and the warmth of our welcome, but also because of the rapid recovery program that we have in place here that allows people to get back on their feet quickly following this kind of operation. It's not just me who works here. There are more of us here who perform hip and knee surgery. There should have been one of, I'm not going to name names, but one of these people, one of this rogues gallery, was meant to be talking about knee replacements this evening, but got called away on an urgent skiing holiday. So I'm going to do both today. If you look at how many operations are performed here at Benenden annually, you can see that we perform almost 2,000 hip and knee replacements per year, which is head and shoulders above most of the institutions in Kent and Sussex. So I'm going to start by talking about total hip replacement. I'm going to talk a little bit about arthritis of the hip, and then I'll go through the consultation process, what treatment options we normally discuss, then the surgical journey, and then what particular risks and problems are associated with this kind of operation. So osteoarthritis of the hip is basically what we call wear and tear. It's when the hip joint wears out. It tends to be of gradual onset. It kind of creeps up on you, really. However, it can come on very acutely. The typical decline that you see in most patients, every now and again you'll see someone who's absolutely fine until they're not. So the pattern of onset can be gradual, can be sudden, can sometimes be related to a trauma. There tends to be no specific single cause for osteoarthritis, but family history is a huge one, as is occupation, sporting activities, weight, and previous injuries. There's no treatment for arthritis, as in there's no cure, there's no pill that you can take that will make it go away. There are many ways that you can find to live with and deal with arthritic joints, and joint replacement is very much the last resort when all of those different treatment modalities have failed. The number one aim when you're dealing with arthritis of the hip is to try and preserve the joint. Surgery is very much a last resort. The average age for someone in England to have a joint replacement, be it hip or knee, is 69 years old. This is average, and we get people from teenagers to over 100 who end up needing joint replacements, hip replacements. And what I've noticed over the last decade or so is that people are getting younger, and people are getting to the time where they need surgery at a younger age than they were when I started out. So what happens when you first come through the doors? Well, there's an initial consultation. You will have been referred here either through your GP or self-referral through contacting the hospital directly. And the purpose of that consultation is to get to know each other, really, to figure out exactly what the problem is, what your limitations are, what your expectations are, and whether or not there's anything that can be done to help. I take a detailed history of your problems and the pattern of symptoms that you have, and we also look at your previous medical history as well. We take a thorough physical examination, and we take some imaging as well. Generally, that would involve X-rays. X-rays are instant and available on site. We also have different imaging modalities like MRI scans and CT scans. They tend not to be instantaneous. Often we have to book them. Generally, the plain X-ray will be the initial investigation. If any further imaging is required, then we will arrange that here. Once all the imaging is in place, once we've got the history, once we've got the examination, once we know what's going on and what can be done, then we can talk about how best to manage your problems. Treatment options with arthritis of the hip. Generally, the first thing is if you are overweight, and by overweight we mean seriously overweight. We're talking about a body mass index of over 40, which is classified as being obese. If you do have a BMI over 40, the number one thing that you can help to do is lose weight. This takes pressure off the joint, makes things feel better, but it also puts you at a lower risk of developing problems during and after the operation. Most private hospitals will have a cut-off point as to a body mass index that they are happy for patients to come along for planned surgery, and that tends to be around 40 as well. The non-operative treatment options are things like physiotherapy, activity modification, exercise, and painkillers in the form of anti-inflammatory medications, either tablets or gels that you rub on, and also painkillers, whether they be pills or patches, to try and alleviate the symptoms. Alternative therapies such as acupuncture, reflexology, all this kind of stuff, again, very useful and very helpful to help someone live with a painful arthritic joint. Sometimes you may be suitable for an injection into the joint. This tends to be more common with arthritic knees rather than hips. Arthritic hips, there's a very special set of circumstances required, but we do perform steroid injections into the hip joint. This tends to be done in an operating theatre, though, under a heavy sedation or a general anaesthetic. If those non-operative treatments either fail or they stop working, and if your quality of life becomes unacceptable, then you'd be looking at surgical intervention, and around the hip, the main surgery there would be a total hip replacement. So the surgical journey starts with that consultation, with what we call prehabilitation. So making sure that you're fit and healthy enough for the operation, starting to exercise, starting to move before the surgery takes place. The stronger you are, the more mobile, the more supple your joints are, the stronger your muscles are that are surrounding your joint before the operation, then the quicker you will recover afterwards. So that's a very important thing to get moving as much as possible. You will have a what's called a pre-assessment appointment, where you meet the nurses, the physiotherapists, and quite often the anaesthetists as well, and that will be basically an MOT to make sure that it's safe for you to have your surgery performed in a private hospital such as this. That pre-assessment will involve a pre-optimization, looking at control of chronic diseases such as blood pressure or diabetes, to make sure that everything is safe to proceed with surgery. The pre-operative phase is also where the education and the planning of our rapid recovery protocol starts. The surgical journey itself, you'll come into hospital on the day of the surgery. We tend to, although we operate all day, our operating lists are split into morning and afternoon sessions. So you will either be admitted early in the morning, 7 AM, or around lunchtime, depending if you're having your surgery in the morning or the afternoon. Typically, the kind of anaesthetic that you will have for a hip or a knee replacement is what's called a spinal anaesthetic. That's where you have an injection into the lower part of your back, which puts your legs to sleep. Now, a lot of people are concerned about a spinal anaesthetic. They're worried that they will be awake during the operation. They're worried that they will hear all sorts of banging and crashing and unpleasant noises and sensations, and just generally not be comfortable in the operating theatre. This generally isn't true. On top of the spinal anaesthetic, you will also have some heavy sedation as well. So you will, at a minimum, feel a pleasant floating sensation, but most of the time people are pretty much asleep during it and remember absolutely nothing following it. Immediately after the operation, you'll then go into the recovery ward, where you'll be closely monitored to make sure that your observations are stable following the surgery, and then you'll go back up to your room on the ward. You'll be in hospital for either 1 or 2 nights following your operation. We tend to see that more and more people are going home the following day, which is pretty impressive, actually. You'll be allowed to fully weight bear immediately after the operation. As soon as your legs wake up from the anaesthetic, we will get you up and about and give you that confidence, even on day 0, that you're standing, that your hip replacement is strong enough to hold your weight, and that will help with your early recovery and discharge. And whilst you're an inpatient, you will receive lots of intensive physiotherapy as well to get you back on your feet and get you comfortable and confident to get back out into the world once you're discharged from hospital. So day one post-operatively, you'll have an X-ray, you'll be reviewed by the ward doctors and also by your surgeons. We'll get you up and about, you'll be going up and down the stairs, we'll do blood tests, we'll do X-rays, and quite often, like I said, more often these days, you'll end up going home that day. Day two, if you're in for day two, you'll have more physiotherapy, and again, once you're safe and comfortable to go home, you'll get to go home. When you do go home, you'll go home on medication. That medication will include painkillers. It will also include a course of blood thinners or anticoagulants. These are prescribed routinely following hip and knee replacement surgery to minimize the risk of blood clots in the post-operative period. You'll be seen as an outpatient by the physiotherapist, and you'll also be seen by your surgeon, again, normally at about 6 weeks post-operatively. There's mention of hip precautions at the bottom here for the first 6 weeks. Generally, there's a list of things that are advisable that you don't do in the early stages following a hip replacement. The trouble with hip replacement surgery is that it is so good at rapidly getting rid of people's chronic pain that they equate the loss of that pain with recovery from the operation and are trying to run before they can walk. This operation does take time to get over, and the muscles and tendons around your hip need time to strengthen and to rebuild and to heal following the surgery. So it's important you don't do too much too soon. At the 6-week post-op appointment, most people following hip replacements at 6 weeks are actually, they walk unaided at that stage. Most people seem to get rid of their crutches or sticks at about 3 or 4 weeks after the operation. Driving, it depends on which hip you've had done and what kind of car you've got, whether or not it's safe to drive. Essentially, you need to be able to control the vehicle with your right leg. You need to be able to stamp on the brakes to perform an emergency stop without hesitation. That generally is around about the 6-week period, but everyone is different. Everyone recovers at a different rate. Some people, it's a couple of weeks. Some people, it's a couple of months. Really what feels best for you. There are complications associated with the surgery. It is a big operation to go through. And although it is big, it is routine. We do them day in, day out, but complications, problems do occur. The thing that we worry the most about is infection. Infection is a potentially catastrophic problem following any kind of joint replacement surgery and can result in multiple subsequent operations, including having to remove an infected joint. So it's a big bad thing to happen to someone and something that we take very seriously. The infection rate here at Benenden is one of the lowest in the country, but it's not zero. People do get infections, and if you do get an infection, then we have to deal with it. Blood clots I've already mentioned. There are really 2 types of blood clot. One is called a DVT, which is a blood clot that you can get in the lower leg. That can give you pain and swelling in the calf muscle, but not much more than an inconvenience. The problem blood clots are the ones that form in the lungs, so called a PE or pulmonary embolus, and they can be potentially catastrophic. So everything about how we prepare people for surgery and how we treat them during and after the operation is designed to minimize the risk of blood clots, but it doesn't completely eliminate it. The other complications that can occur, you can have damage to the nerves that supply the skin or the muscles around the leg. Hip replacement in its early stages can dislocate, can pop out of joint. That tends to be why we tell people to take things easy to start with while everything heals, and so you can minimize the risk of dislocation. It is possible to change the length of your legs during surgery. We tend to plan to restore the length of the leg back to how it used to be before you developed arthritis, but sometimes people can feel a bit longer or a bit shorter after this operation. Another complication, wear and loosening. That's not really a complication, that's simply a fact. Artificial joints, even modern artificial joints with incredibly long-lasting and hard-wearing bearings, they still do wear out eventually. So the younger people are, and the more active people are following joint replacement surgery, it is more likely that the hip joint may wear out. Modern implants last decades, but not forever. Whistle-stop tour of hips. Now we're on to knees. There's quite a lot of crossover between the two, so I'll skip through those things. Again, it's a common operation. Again, around 100,000 are performed in the UK, and about 1,000 of those happen here at Benenden. Again, the average age is mid to late 60s. There's a slight majority of ladies having both hip and knee replacements compared to men. Again, they're very good operations, and the overwhelming majority of people feel better for having had them done. And again, they last an incredibly long time. Reasons for knee replacement. Again, the commonest reason that we see is arthritis, and that kind of arthritis that we deal with most is the osteoarthritis, the wear and tear kind. There are other forms of arthritis, inflammatory arthritis. These are more of a disease that affects your body and can affect your joints and wear them away. The commonest of those inflammatory arthropathies is rheumatoid arthritis. There's been a dramatic change in the treatment of rheumatoid arthritis since I became a doctor. In the last 25 years, the treatments available with biological agents has really revolutionized the treatment of rheumatoid arthritis. And at one stage, when I started, about 1/3 of all joint replacements were for rheumatoid arthritis. Now it's about 1%. So there's been a huge advances in the treatment of rheumatoid, leading to less people with burnt out, worn out joints from rheumatoid. There are other inflammatory conditions such as gout and pseudo gout that can also lead to worn out joints and knee joints. Post-traumatic is another reason for developing arthritis or for needing surgery. Either broken bones or severe ligament injuries can cause instability of the knee joint, leading to premature wear. Again, the aims of any kind of treatment, including knee replacement, are to get rid of the pain, to allow you to mobilize more and get back to living your life, really. The other thing that we can do, especially with knee replacements, there's a couple of examples at the bottom of the screen there of what we call a varus knee and a valgus knee. So your legs can either bow outwards, or you can develop quite a severe knock-knee deformity with arthritis. And knee replacement surgery will restore the normal mechanical alignment of the knee. Again, I mentioned with hips, we're seeing a lot of younger patients. The average age is dropping, and younger people want to do more. So people have a higher function, higher demands, greater expectations. So all of these, with advances in technology and harder wearing implants, along with rapid recovery, we're trying to meet those with technology to try and improve outcomes and the longevity of implants. The symptoms of knee arthritis, pretty similar to hip, really. The main thing is pain. Along with pain is stiffness. Generally, it starts off with pain with activity, but then develops into pain at rest, and night pain particularly is a bad sign. With stiffness, then leads on to deformity, reduced function. You can also get creaking and grinding and clicking and swelling of the joint. With particular patterns of arthritis, you can also get quite severe feelings of instability in the knee as well. And once you lose faith or trust in your knee, it's very difficult to continue living with it the way it is. Treatment options, again, you break into either surgical or non-surgical. The non-surgical options, again, activity modification, exercise, movement, weight loss, physiotherapy. Strapping and bracing people can find useful as well. and again, painkillers and anti-inflammatory medications. Injections, there are more injection options when it comes to knees as opposed to hips. Injections, again, you can do anti-inflammatory steroid injections. There are also lubricants that you can inject into people's knees to try and allow them to move a bit more freely. There are also newer injections that are being developed, things like PRP and stem cell therapy. At the moment, these are experimental, but this is where the future of injectable therapy goes. They're suitable for a very small number of people at the moment, and not common practice and not generally funded by insurance companies. They have to be self-funded. As far as surgical options go, you can realign the knee joint to take the pressure off worn areas. That is quite a rare thing to do here at Benenden. It's rare that we see someone who is suitable for that kind of surgery. Keyhole surgery can be useful in the early stages of arthritis, not to deal with the arthritis itself, but to deal with some of the consequences of arthritis, such as degenerate tears in the cartilage, or loose bodies floating around, or smoothing off rough surfaces to try and improve movement and function in the knee. But the mainstay of surgical treatment of arthritis is joint replacement. Now, knee replacement, there are lots of different types of knee replacement, whether you replace part or all of the knee, and ultimately that depends on the particular pattern of disease in your particular case. If you are suitable for a partial knee replacement, such as called an Oxford medial unicompartmental knee replacement, then generally my advice would be to have a partial knee replacement if suitable. These are slightly less of an operation, but more importantly, they tend to feel a bit more natural than an artificial total knee replacement can. When it comes to total knee replacements, there are different brands and different types and different ways of performing this kind of surgery. There are many different innovations looking at trying to make knee replacement surgery more accurate, and I'll talk about them a little bit later on. The bottom part, talking about constrained knee replacement, these are the extreme operations when you're either talking about redo surgery or in people who've got severe deformity or multiple ligament failures. Again, they're fairly highly complex specialist operations that it's rare that we do them on site here. The commonest form of knee replacement surgery that we do here is a Vanguard knee replacement. That's the brand name. There's two pictures of them there. It's manufactured by a company called Zimmer Biomet. It has an ODEP rating, which is a safety rating to see how well these things work, and the Vanguard has the highest ODEP rating that is possible. Looking at the figures, looking at the activity and survivorship of this kind of knee replacement, these again, they last decades. 97% 10-year survival for this kind of implant. So they're incredibly reliable, long-lasting things. They are cemented. We use what's called cement to fix them in. It's not actually cement, it's actually an epoxy resin that acts as a grout, an interface between the bone and the metal, the undersurface of the metal implants to hold everything in place, with or without patella resurfacing. So you can replace the undersurface of the kneecap as well. I tend to do that about 75% of the time. Every now and again, someone's knee is worn everywhere apart from the kneecap, in which case we can leave that kneecap alone and just replace the rest of the knee itself. I mentioned about new technology, different ways of people trying to increase the accuracy of this kind of operation. Customized knee replacements have been around for a couple of decades now, actually, and I think the fact that they've been around for so long but still are a fairly niche procedure tells you really everything you need to know about them. The amount of customization and personalization that you can achieve with standard knee replacement implants means that it is very unlikely that you need to have one specifically built for you. The times when customized implants really come into their own are in cases of extreme deformity or in revision surgery. Navigation and robotic surgery are essentially the same thing. This is a picture on the screen there. This is a Rosa, who is she is the one of the company's knee robots. Robotic surgery or navigation surgery is all designed to try and make the cuts in the bone as accurate as possible to try and allow you to implant the knee as accurately as possible. The jury's still out on whether or not robotic surgery is of benefit. It is a procedure that is being driven quite aggressively at the moment by the companies, by the implant companies that manufacture their robots and the implants. And there's uptake of it in several centres around. Here at Benenden, it's something that we are looking at. I think it's important not to jump on the bandwagon, and we are looking at ways of implementing it if it will be of benefit to patients without causing it to be prohibitively expensive. What happens after the knee replacement? Well, the same as the hips, really. You are monitored down in the recovery area and then back up onto the ward. Knee replacements, pain management is very important, and that will be with painkillers, also with ice packs to try and help alleviate swelling and tightness around the knee. Mobilization, physiotherapy, working on getting your knee moving and bending. Again, the normal checks of blood tests and x-rays. More likely to stay in hospital for 2 nights than a hip replacement would. But again, a reduced hospital stay due to the rapid recovery program, getting you up and about afterwards, and again going home with the normal anticoagulant medications and follow up with the physiotherapists and with your surgeons as with a hip replacement. Again, the risks of knee replacement similar to those of hip replacement. The one complication that is more specific to knees than hips is stiffness or swelling, well, stiffness in particular. Knee replacements in the early days are quite painful, and the success of a knee replacement depends on getting a good range of movement in the early days. So in the first month or two, it's important to get your knee moving as quickly as possible. The trouble is that it's painful and people can get stuck in those early stages, and people will end up with stiffness as scar tissue forms around the knee before the range of movement has been achieved. In that case, sometimes you need further help, surgery, to break down that scar tissue to try and get the knee moving again. So stiffness of a knee is a complication that you can see. Again, infection, again, wear and tear and revision surgery, again, needed towards the end of the knee replacement's life, which many decades down the line. There are lots of different ways that you can find out about whether or not it's right for you to be thinking about joint replacement. There are you can look at your surgeon through the National Joint Registry. Every surgeon has a profile on the NJR, and that will tell you what level of how many operations they do, what their case mix is like. You can also look at satisfaction levels and patient reviews and scores, either on review sites or through the private health information network. There are lots of patient support groups out there. A lot of my patients find that there are Facebook groups that are useful, and lots of they tend to be more American based, but again can give you lots of tips and tricks about before and after the surgery. the website at the bottom there is a way for you to be able to visualize how much better off you will be following a joint replacement. You type in your particular details and your particular symptoms, and it's part of the National Joint Registry. It uses the data from hundreds and thousands of previous people's operations and satisfaction levels to predict exactly what your response will be and exactly what your tailored risks are for any particular operation. It's a very useful thing to do and worth looking at if you want an idea of how things will be, particularly for you following this operation. That is about it from me. I'm sorry, that was quite a whistle-stop tour of hip and knee replacement surgery. Please feel free to answer some questions and ask some questions, and I'll do my best to answer them.
Okay, thank you for those insights into the patient journey. Some excellent detail on treatment options there, and we've got quite a few questions coming in to get through. We'll do our best to get through these. So this person asks, what symptoms am I likely to experience as a hip replacement starts to become necessary?
As a hip replacement starts to, so the symptoms that you will get, the symptoms of arthritis of the hip, initially, most people dismiss it as a groin strain or something like that. So you tend to get pain right in the groin, right at the front of your thigh. And that pain initially will come on. It may well come on when you sit down, or when you're standing for long periods of time, or taking part in prolonged activity. What then tends to happen over time is that pain will spread. It can radiate around the back into the buttock and also down the front of the thigh towards the knee. The severity of the pain will increase, and the duration of your symptoms will increase until you get to a stage where the pain can be there at rest, disturb your sleep, and be there pretty constantly. Along with the pain, you'll get stiffness, and that tends to manifest itself again with a hip replacement, or potential for a hip replacement, looking at things like finding it a struggle to put on your shoes and socks, getting down to cut your toenails can often be quite difficult, getting in and out of cars, that kind of thing. You may find that your walking distance decreases, that you particularly struggle on uneven ground and hills. So that would be how it starts and progresses.
Okay, thank you. Next question. You mentioned outpatient physiotherapy. How frequent is this, and is it arranged before leaving hospital?
It is, and it is. Obviously, it depends on where you are. Benenden is lovely, as in it's lovely in the countryside, but it is. We get patients who come a long way to have surgery here, and it doesn't make sense for those patients to have their physiotherapy here afterwards because the journeys are too long. So if you do come from a way away, then your physiotherapy can be arranged local to you. This would be through the Benenden head office in York. Most people will find that there are approved physiotherapists local to you. I would advise that you arrange that before you come in to surgery, because quite often arranging local therapy can take a couple of weeks to set up, and you don't want to be waiting for that to start after you've had your operation. Generally, if you are local to here, or it's convenient for you to come here, then like I said, the physiotherapy actually starts in the pre-assessment clinic. And then you'll be seen on the ward, and you'll have to satisfy the physiotherapist that you're safe to go home and able to cope. Most physios afterwards, they will tend to see you about either 2 or 3 times in that first 6-week period, really depending on how you are. The physiotherapy is not just something that you do when you're with the physio, though. It's something that you have to keep doing yourself every day. The physio is mainly to monitor your progress and to guide you, but it has to come from you.
Okay, this next attendee asks, I'm 61 and I still work full time. I've been recommended to have a knee replacement. I do quite a lot of repetitive heavy lifting at work. Would I still be able to do this for a few years after I've fully recovered?
As I've said, people are having joint replacements younger and younger, and they tend to be more demanding and either demanding professions or demanding activities afterwards, and it is difficult. Ideally, it always used to be that joint replacement surgery was for after you retire. That's not really the case anymore. Most people do get back to work, and I tell people normally to take about 2 or 3 months off work, but you will get back to it. Typically, most people who are at the stage where they have a knee replacement, they can no longer do that kind of heavy manual stuff at work anyway. That's one of the reasons that they come to have their operation. If your level of function is still high enough that you can do a very demanding job, then it may be that it's not quite the time to have a knee replacement just yet. If you find that you're struggling at work because of your knee and you can't do what you need to do to fulfill your job, then after a knee replacement, you should get back your movement, you should get your strength, but it will take time and it will take effort, and it's not 100% guaranteed that you will get back to the level that you want.
Okay, the next question is, does Baker's cyst impede a knee replacement? Can you get rid of the cyst in any other way?
So a Baker's cyst is a collection of fluid that comes from the joint and bulges out the back of the knee. So quite a lot of people with arthritis in their knee, they'll feel a lump in the back of the fold of their knee, and that's a Baker's cyst. That fluid is formed inside the knee. It's your body's response to a worn out joint. Your body's trying to produce more fluid to lubricate the joint and allow it to move more freely again. And that excess fluid gets forced out the back and bulges out the back of the knee. It doesn't impede a knee replacement at all. It's a sign that you might need one, because it's a sign of there being a problem inside your knee joint. Knee replacement surgery does not cure a Baker's cyst. Once that Baker's cyst has developed, once that potential space out the back of the knee has formed and the fluid has been forced out through that, then fluid can always get forced out again. The difference after your knee replacement, though, is that the knee will produce much less fluid than it was beforehand, because your knee will be calmer and in less trouble and less inflamed and angry. So people who have Baker's cysts may still feel some fullness in the back of their knee following knee replacement surgery, but it's never quite as extreme or as painful or problematic as beforehand.
Okay, this person asks, if you have a Vanguard knee replacement, does that mean you would have to have another one in 10 years?
No. There we go.
Simple as that.
Simple as that. I mean, any artificial joint, it will, one of two things will happen. Either it will wear out or you will die. Eventually, one of those things will happen. If you die before your joint wears out, then it lasts you the rest of your life. If a joint replacement wears out or needs revising before, at any point, then yes, you'll need another one. But it's not 10 years. The days of these things only lasting 10 years are long gone. These modern implants last much longer than that. There are some reasons why people need early revision surgery. They tend to be the problems such as infection or broken bones or ligament damage, that kind of thing, the sort of post-traumatic almost reasons for revision. They can come on at any time, particularly the early ones. Knee replacements or hip replacements wearing out does happen, but many years.
This attendee asks, who determines how long I am an inpatient? Do complications become apparent immediately? And what happens if complications arise after discharge?
Who determines? So the discharge process is it's a multidisciplinary one, really. Everyone has certain targets, criteria that they are happy with people going home, and they are different from what I'm happy with, to what the nurses are happy with, to what the physios are happy with, to what you're happy with as well. So essentially, the team will come to a decision. If everyone feels that you've reached the right level of function to be able to go home, including yourself, then you get to go home. That typically, like I say, is around the 2 nights in hospital. Sometimes it can be 3 or 4, sometimes it can be 1 or none, depending on whether or not you meet all the right criteria. Complications, they can be apparent if the complications can come on early, medium term, or late. So obviously a complication can become apparent whilst you're in hospital, and if it does, then it can be dealt with there and then. If you develop a complication once you have been discharged from hospital, then yes, the first port of call, if you have any concerns or worries, the first thing is to get in touch with the institution, wherever it may be, the institution where you had your surgery. Generally, that would either be to ring the ward if you just got home and noticed a problem, either ringing the ward, and one of the senior nurses on the ward will be able to answer any questions or worries you might have, or ringing up the secretaries here, the orthopaedic secretaries, who can then pass on a message to your surgeon to arrange either you coming up to the ward to be seen, or to be seen more urgently in the outpatient clinic. There are some complications that we can't deal with on site. And if those happen, so because we don't have an emergency department here, we don't have an intensive care here, if people develop serious complications that require a level of input that cannot be provided on site here at Benenden, then you will either be advised to attend your local hospital, or if you are here, then you may be transferred to a local hospital that has enhanced facilities. Fortunately, the level of transferring patients out of hospital is very, very, very low. But it's again, if needed, we have an agreement with local hospitals. It's a seamless transfer.
Okay, on to the next question. Following surgery, will full mobility be returned?
The best prediction of what kind of movement and mobility you will have after the operation is what you have before the operation. So if you have not fully straightened your knee for decades, it would be unrealistic to think that you will immediately have a full range of movement in your knee. All that joint replacement surgery does is it replaces the worn out joint surfaces that are rubbing and grinding against each other. What you need to also, what determines your function and your level of movement is the state of repair of the muscles and ligaments and tendons that support and move your joint. That's why it's so important before an operation to try and be as mobile and flexible as possible, because the recovery depends on you moving it, you using it, and building up the strength, the confidence, and the stamina in the muscles again. Having said that, generally, most people's level of function following joint replacement in a normal situation gets back to pretty much normal, but it does take time. It takes work on your part as well as mine.
Okay. Next question is, can a hip replacement be done via keyhole surgery?
No. There are, I mean, keyhole surgery, the technical definition of keyhole surgery is incisions that are about 4 or 5 millimeters across. And the size of the implant means that you can't get those can't get things in through that size hole. You can perform what's called a minimally invasive hip replacement, which is where you try and make the incisions as small as possible. A minimally invasive hip replacement is defined as a hip replacement that has an incision of less than 12 centimeters. Generally, that really depends on your personal shape and size. If you have a very large leg, then the minimally invasive surgery becomes more and more difficult. Essentially, a hip replacement is performed through, and a knee replacement is performed through the size of the incision that is required to put it in properly and safely, and not 1 millimeter more.
Okay, this gentleman seems to be suggesting that he may need 2 knee replacements, and he's asking what the time span would be between each of those procedures.
So bilateral knee replacements, we do in exceptional circumstances, we can perform them at the same time on the same day, bilateral joint replacements. I do hundreds of joint replacements every year, and about once a year I will do a bilateral knee replacement. The reason being that you need that unique mix of someone who is as equally as debilitated with both knees, but who is also young and healthy enough to undergo essentially a double operation, which is a major procedure. More common is a sequential or a staged procedure where you have one knee replacement and then the other one done at a later date. Generally, I advise people to wait about 6 months between sides if you can. That gives you enough time to fully recover from the first side, and also to build up the strength and reserves that you'll need to go through it all over again. So 6 months on that.
Okay, this attendee asks, last time I saw a consultant about knee replacement, he told me to wait until I was in agony. Would you agree?
Depends on your definition of agony. My advice tends to be that you live with your knee as long as you can, but when you get to the point where you can't live with it anymore and you can't find any other way of dealing with it, then it's time to have your replacement. Like I mentioned in earlier answers, getting to the point where you're housebound or completely immobile generally isn't a good thing. It means that you will be weaker, your recovery will be tougher, your surgery will be more complicated. So, don't wait until you can't leave the house. It is very much though, it's the last thing you do. So you need that balance between being able to live your life or do what you want to do and not suffering unnecessarily.
Okay, this next question is, does being overweight preclude you from all treatments, both surgical and other methods?
No. Do you want me to elaborate?
A simple one.
No, I mean, so if you, another statistic which is on a different talk, not that one, the majority of people who have knee replacements in the UK have a BMI over 30, and a BMI of over 30 technically puts you overweight and is knocking on the extremely overweight category. So no, being overweight doesn't preclude you from surgery, and it doesn't preclude you from any other treatments. Being morbidly obese, having a BMI of over 40 will limit your choices as to where you can have your surgery and who would be happy to perform that surgery. Generally, the first line of treatment before you ever get to surgery will be to try and lose weight, because that has huge benefits on your general health and fitness, as well as the pain that you're currently in, the safety of the operation, and the longevity of the implant afterwards. So people will, if you are overweight, people will keep advising you to lose weight. It's not because that's the only way you get treatment, is because it's the first line of treatment and it will make everything else so much easier. I do appreciate, though, that you're dealing with a problem that renders you immobile. Telling someone who can't move their knees or who can't get out of a chair without help to go and do some exercise and lose weight is unrealistic. If you are extremely overweight, then the first treatment may well be weight loss surgery in order to help you lose weight if you can't mobilize, before you end up having a joint replacement. I know it's another topic, but there are many, several weight loss surgeons here, and if you book into another one of the webinars, there's always one, quite common one, about weight loss surgery that performed here. So, if you're massively overweight, then that would be the first thing to do. But no, it wouldn't preclude you from any particular treatment, really.
Okay, this lady asks, can a hip replacement solve soft tissue pain around a moderately arthritic hip? I had an arthroscopy op 8 years ago and still have pain.
So it depends on so soft tissue pain around a hip depends on the cause of that soft tissue pain. Now, if your soft tissues are painful because the muscles and ligaments around your hip are struggling to move that hip because it's very stiff and very worn, then a hip replacement will allow everything to move more smoothly and have a knock-on effect on that. I wouldn't recommend that you have a hip replacement as a primary procedure in order to deal with the soft tissue problems around that hip. It seems like a bit of a sledgehammer to crack a nut. Generally, the soft tissue pain and the deep hip pain tend to be linked together, and so can, as a result, having a hip replacement can help, but I would try and exhaust all soft tissue measures first before going down that route.
Okay, this gentleman asks, I have a knee operation next Wednesday with Mr. Goddard. The pain I want to cure is pain from the knee down to the foot when standing and joint pain when walking. Can I travel home alone by taxi?
Depends where you are.
Yeah, they don't specify.
Like I mentioned earlier, we have people from all over the place here, and they regularly. I operated on a man from Wales this morning, so we get people all over the country who come and have their surgery here, and they do have to get home again. Generally, most people are safe to travel. It's always nicer to travel with family rather than in a taxi. It's cheaper as well. But yes, you will be able to sit in a car for a period of time. You may find that if your journey is more than a couple of hours, then you break up the journey, you stop, you stretch your legs, you get up and about halfway there, that kind of thing. But no, it's perfectly safe to travel to and from by car. I wouldn't recommend you drive, but having friends or family drive, or indeed a taxi if necessary. The fare might be a bit higher because you may need to break up the journey.
Okay.
You mentioned about the pain. I'm sure. So Richard is a very experienced surgeon. He knows what he's doing. If he has seen you and assessed you, and he's confident that the knee replacement he's going to perform will help your symptoms, then it would be the right thing to do.
Okay, we are nearing the end of the session now, so I'm afraid we've run out of time for questions, but I'm sorry if we didn't answer your questions, but if you've provided your name, we will do so via email, endeavour to answer your questions. If you'd like to discuss or book your consultation, our private patients team will be available to take your phone calls this evening until 9 p.m. or between 8 a.m. and 6 p.m. Monday to Friday. We're offering a discount for all attendees of this session for 7 days with the terms listed on the screen, so you can take advantage of that. Following this, you'll receive a short survey, and we'd be grateful if you could take a few minutes to give us your feedback on this session. Our next webinar will be on the 14th of March, covering varicose vein treatments, and you can visit our website to sign up for that. All that remains for me to say is, on behalf of our team here at Benenden Hospital, I'd like to say thank you very much for tuning in, and we hope to hear from you very soon. Thank you and goodbye.